education consultation to prescribers, pharmacists, and healthcare teams around the state. Our information is in the corner of the slide, and Marcial will be providing information in the chat, so feel free to reach out to us with any questions. I'm going to briefly introduce Dr. DePaula and then hand the floor over to her for the rest of the hour. I want to just make note that on today's webinar, we are going to be using hopefully very successfully the technology you see here with a QR code on the left side of your screen for some interactive polling and word cloud. So you can feel free now or as the webinar goes on to scan this QR code. And Dr. DePaula will ask for some interaction throughout the presentation. You'll notice that your name might pop up as you register, but your name won't be associated with any of the questions, just the answers you provide or the words you enter during the word cloud. But we appreciate you engaging with that to just make the presentation a little more interactive. If you have questions about that or need support, feel free to drop those in the chat, and Marcial or Zach, who's on to provide IT support, can give you some feedback or support as needed. So we are really excited to have Dr. DePaula join us today for the presentation. She is a Max consultant and a professor of practice sciences and health outcomes research at the School of Pharmacy at the University of Maryland. She's the co-director of the mental health program, and she received her Doctor of Pharmacy degree and completed a psychiatric pharmacy specialty residency here at the University of Maryland School of Pharmacy. Her research and teaching focus involves psychiatry, and substance abuse. She serves as the director of the University of Maryland Psychiatric Pharmacy Residency Program and is a board-certified psychiatric pharmacist with inpatient and outpatient psychiatric and substance abuse practices. In addition, she's worked as the director of pharmacy at 2 Maryland state psychiatric hospitals. Dr. DePaula has presented and published research related to psychiatry, substance abuse, and academics, and she's specifically interested in comorbidity of psychiatry, and substance abuse. We are excited, as I mentioned, to have her join us today, and I will turn it over for her to talk more about what she'll cover over the next hour. Thank you, Dr. DePaula.
Great. Thank you so much for that wonderful introduction. Can you hear me okay? Excellent.
Yes.
All right. So today we're going to be focusing on optimizing the pharmacy partnership in managing patients with opioid use disorder. And this is what I hope to do today. I hope by the end of this presentation, you'll be able to describe some innovative roles for pharmacists in managing patients with OUD, identify barriers for management, particularly in a community pharmacy setting, and create some strategies to optimize access. So I think that we're probably all aware that we have been experiencing an opioid crisis that has persisted for decades. And it is really an all hands on deck situation, and we really need to utilize all healthcare professionals to the full extent that we can. So a couple of points that I want to make about pharmacists and pharmacy accessibility include that pharmacists are trusted healthcare professionals. There's all kinds of Gallup polls that have established that pharmacists are trusted in the community. And probably as important or even more important is the accessibility of community pharmacies. So this is a study that was completed by Barenbrock and colleagues in about 2022. It was published, and it basically looked at accessibility of community pharmacies, and what it found was that about 89% of those 89% of the population live within 5 miles of a community pharmacy, and almost 97% live within 10 miles. So this really supports why pharmacists need to play a role in managing patients with opioid use disorder. And I also want to make the point that pharmacists genuinely want to provide patient care and want to help. We go to pharmacy school and receive a lot of training around particularly medication management for chronic diseases, monitoring, patient education. This is kind of our bread and butter of training and part of why we go to pharmacy school. So these tiles represent various services that pharmacists provide to patients with substance use disorders. A lot of them happen in the community pharmacy, but not exclusively the community pharmacy. And I could probably do an entire presentation discussing all of this in a little bit more depth. So I'm just going to kind of cut to the chase and state that I'm mostly going to be focusing on the three bottom tiles, a little bit on injection administration, and more on MOUD, particularly buprenorphine, and a little bit on collaborative drug therapy management. So I think probably a lot of us are familiar with the pharmacist at the bottom of our screen, but maybe a little bit less so with the pharmacist at the top of our screen. And so I want to talk a little bit about pharmacist scope and pharmacist responsibilities and aspects of pharmacist scope that all pharmacists have, and where there might be some differences either between pharmacists or between states. So all pharmacists as licensed pharmacists in the US can dispense medication, they can compound medication, they're responsible for medication profile review, which means ensuring that the patient is getting the medication that was prescribed at an appropriate dose that is indicated for what is being treated and that there aren't other issues such as drug-drug interactions. Where you start to see some variability is when you hit these three other bullet points. So, administration of vaccines. That is a newer aspect of scope of practice, and pharmacists in the state of Maryland have to be certified to administer vaccines. So that either means completing training during pharmacy school. Most pharmacy schools throughout the country now train pharmacists to administer vaccines so that when they graduate, the the pharmacists can administer. But for pharmacists that are older, like myself, you may not have had that as part of your pharmacy school training, in which case, if you're going to administer vaccines, you have to complete a training through the American Pharmacists Association and you become certified and then you can administer. So in the state of Maryland, you actually have a designation on your license. And I completed that extra training so I could administer vaccines. And many of the pharmacists that administer vaccines do this in the community pharmacy setting. So our pharmacists at the bottom of the screen. Long-acting injectables is something where there's a lot of variability and it really does depend on the state. So in the state of Maryland, as of a couple of years ago, there was legislation that was approved that allow pharmacists to administer certain long-acting injectables. And this includes long-acting antipsychotics and medications to treat substance use disorders. So we can administer Brixadi and Sublocade and Vivitrol. But like the vaccines, you have to have either been trained in the pharmacy school or received outside training in order to administer vaccines. So we just started at the University of Maryland training, and we've been training for the last 2 or 3 years in our labs so that when our pharmacy students graduate, they can administer these type of long-acting injectables. But for most pharmacists, they have to complete some sort of outside training in order to administer. Then management of drug therapy. This is probably more what our pharmacist at the top of the screen is doing. This is working collaboratively with a team and providing direct patient care where you are monitoring patients, you're working with the team to optimize and make recommendations about dosing and appropriate medications based on the indication at a team level. And this could either be inpatient or in a clinic type setting. And then some pharmacists that practice collaboratively also may have practice agreements. They're called different things in different states. Some states call them collaborative drug therapy management agreements. Some of them call them collaborative practice agreements. The VA actually has a system in its scope of practice, but it basically allows the pharmacist to have some sort of responsibility around actually ordering, changing meds. So it may be starting meds, changing doses, discontinuing meds. It depends on the agreement. But again, some pharmacists have that as part of their scope, but not all pharmacists. Another area that you may be less familiar with pharmacy is specialty practice and the fact that pharmacists specialize, just like other healthcare professionals, really. And so we have an organization, the Board of Pharmacy Specialties, or BPS, and that's our org that maintains our certification process, which involves having specialty training and experience, and then completing a board certification exam. And when you've successfully passed that, you're then board certified, and we have a recertification process that we go through. And this is a list of the various specialties. I've psychiatry underlined, particularly because I am a board certified psychiatric pharmacist. And as part of our training, our residency training and our exam, we do include management for substance use disorders, but there are other specialties that also provide care, just like other medical specialties, emergency medicine, pain management, ambulatory care. We know that we see patients with substance use disorders across the spectrum. With collaborative practice, pharmacists often practice in settings outside of the community pharmacy. So we often work with indigent or underserved patients, either in very urban or rural settings, again, more of in an inpatient or ambulatory with a team. I've included some examples of systems where you might find pharmacists practicing collaboratively. And these three pictures are actually different locations where I've practiced collaboratively. Again, my focus has generally been patients with substance use disorders and comorbid psychiatric disorders and medication management. So I see a lot of patients right now that are being managed with buprenorphine and some with naltrexone. These are some examples of the type of activities or services that pharmacists that work collaboratively generally provide. And I think this type of model really works well with patients with substance use disorders because they often require um, ongoing monitoring, and working in a team fashion can really, number one, optimize care and share the load. So it really makes a great model for care. And again, the types of services that we might provide in this type of setting would be, we can certainly collect a thorough medication history. A lot of patients that are being treated with buprenorphine, especially early on in the treatment, maybe having dose adjustments. And so we can certainly assist with that. Laboratory monitoring, whether that be urine drug tests or other types of lab monitoring, depending on what other medications they're receiving. Monitoring for adherence, so we can certainly assist in PDMP monitoring, for instance. Comorbidities. I find a lot of my patients have untreated or not recently treated psychiatric or comorbid medical disorders. And so we're starting by managing them for their substance use disorder, but many of them are on or going to be started on other medications. And so having a team to monitor all of that can be really helpful. And then any sort of work around insurance, we can certainly help share the load there. So again, collaborative practice itself is not new, but what is newer is looking at collaborative practice and managing patients with substance use disorders in a community pharmacy setting. So I wanted to present a couple of studies that have recently been published. This first study was completed by Wu and colleagues and published in 2021, and it was a proof of concept type study. So they started with patients that had been initiated on buprenorphine for treatment of opioid use disorder in a office-based setting, and then they consented them and transferred them to collaborative care in community pharmacies. And these are community pharmacies that were part of the study and had an established relationship. And in the community pharmacy, the pharmacist took over some of the medication dosing and a lot of the monitoring so that the office didn't have to do that monitoring unless there was something acute going on that needed to be referred back. And what they found was that they had overall a high treatment retention rate, 88% at 6 months, good adherence, 95%. There was enhanced communication between the physicians and pharmacists, which when we talk about barriers is really important and I think is one of the things that made this a successful pilot. They had improved diversion monitoring. The patients liked it. There was less physician burden, so the physicians liked it, and it wasn't really powered to assess for overdose, but they noted that there were no substance-related overdoses. Another study that was even more recently published, just published last year, was more of a randomized design. They took patients, this was completed by Green and colleagues, and they took patients who presented to have buprenorphine initiated, and they randomized them to either pharmacy initiation or standard care office-based initiation. And this is an ongoing study. So the data that I'm presenting is really just from the first month. And the other point that I want to make is that the pharmacies were a little bit different than the first study. The first study were traditional community pharmacy setting. These were actually a network of behavioral health pharmacies. So they were already pharmacies that specialized. And what they found was they that from a retention perspective, 25 out of 28 or 89% of the patients continued care after a month at the pharmacy, and 5 out of 30 or 17% continued care in the standard model. They also, again, not powered for, but looked at safety and found relatively similar safety with each of the arms. The last study looks a lot like the first study, and it was actually also completed by Wu and colleagues, but it's a little bit different view. It basically looks at a relationship between a community pharmacy and an OTP and focused on methadone dispensing in the community pharmacy. So again, they took patients that were already stabilized in the OTP, and these were patients that were very stable. They had been in the OTP for at least a month, sorry, not a month, a year, and doing very well on methadone. And then they moved the care for the study patients for just medication dispensing to the pharmacy. So the patients continued to go to the OTP for other aspects of OUD care, but they were able to pick their prescriptions up in the pharmacy was really the experimental aspect of the study. And what they found was at month 3, they retained 16 out of 20 or 80% of those that participated in the study. And of those that returned early to the OTP, none of them returned early for opioid related or study related reasons. They returned mostly for personal changes that made it necessary that they continue receiving the methadone in the OTP. They also were able to demonstrate 100% medication adherence, and there was good patient satisfaction. So again, from a proof of concept, this study suggests that potentially in the future, patients could to have their methadone dispensed for the treatment of opioid use disorder in community pharmacies. We do know that patients currently are able to pick up methadone for pain in a community pharmacy setting. So this moves us to our first poll question. This is where you want to go ahead and scan the QR code if you would. And what we're going to do is answer the following question, which is which one of the following is an example of how pharmacists can provide care for patients with opioid use disorder? And our choices are A, administer long-acting injections such as buprenorphine, B, educate about the risk for opioid overdose and offer naloxone, C, work collaboratively with a treatment team to optimize and monitor medications, or D, all of the above? So hopefully this is a easy question. I'll give you a few seconds to put your answers in. Okay, looks like we have most of our answers in at this point. And yes, I'm glad we all agree that D, all of the above, these are all potential areas where pharmacists can provide care. So change gears just a little bit, and hopefully this is review and no new information, but buprenorphine has clearly been shown to be evidence-based, safe, and effective treatment for opioid use disorder. And data suggests that it can reduce overdose deaths by 50%. It helps achieve long-term recovery. And there have been a lot of efforts from an educational perspective and from a regulatory perspective to increase prescriber capacity. One of the big changes that we've seen over time has been the removal of the data waiver. So, as many of us probably recall, it used to be that in order to prescribe buprenorphine in an office-based setting to treat opioid use disorder, the prescriber had to be data waivered. But that has been removed, and now any prescriber that can prescribe controlled substances can prescribe buprenorphine in an office-based setting for the treatment of opioid use disorder. So that was really a big change that has continued to expand prescriber capacity. We know that there's still challenges there, and we still would like to see even more prescribers prescribing, but it is a big difference for us. So probably the maybe pink elephant in the room is buprenorphine access and some of the challenges and barriers that are currently occurring with community pharmacy access for buprenorphine. When you look at the literature, it's estimated about half, 48 to 58% of community pharmacies are routinely stocking some formulation of buprenorphine naloxone, which is concerning. There is a substantial variability in this particular statistic. There is a lot of variability among states. There's variability in the type of pharmacy. Some of the literature has suggested that independent pharmacies in certain regions are less likely to stock buprenorphine. I have done a couple of different studies in the state of Maryland looking at buprenorphine access, and we have not found a difference between chains and independents in the studies that we've done. And there's other literature to suggest that there may not be a difference, but again, in some regions, there may be certain types of pharmacies that are more or less likely to stock. And similarly, geographic regions, there's some data to suggest that either very rural regions or sometimes very urban city-centered regions are less likely to have buprenorphine available. But again, that does really vary depending on the literature and the region of the country. So this moves us to our active word cloud. Hopefully this is going to work. This is a little bit of a trial for us. So if you would please scan the QR code. And what I am looking for is basically a patient calls the clinic and lets you know that they cannot get their Suboxone prescription filled from the community pharmacy. And so my question is if you've experienced this before, or even if you can imagine this happening, what were the potential contributing factors? What contributed to why the pharmacy did not have the Suboxone available? And you should actually have a couple of blocks that you can fill in the wording for this. So you have the opportunity to actually put a couple things in. But again, if you could just summarize in a word or two, we're going to have the opportunity to see anonymously what people are experiencing. And I'm going to move to the next slide. I believe that slide is going to show us. When I see participants are typing, I'll give you guys a couple minutes. Great, great. Thank you. So I'm going to be addressing some of this in just a minute. But yeah, availability is a big issue and access and whether stigma is playing a role in that. Cost is a big issue. I'm going to talk about that in just a minute. I think all of us are really feeling frustrated, concerned because of shortages, stock order issues, access issues. So that is very helpful. All right. So these are not my opinion. These are what I have gathered from the research and literature, and also what I've heard from Max calls, but these are some of the contributing access issues. And they kind of fall into three large buckets: regulatory policy issues, pharmacy level issues, employee level issues. So, from a regulatory policy issue, you may or may not have heard of SOARs or suspicious order reporting systems. And in order to explain this, I need everybody to be on the same page about how pharmacies obtain their medications. So for most medications, pharmacies don't order those directly from the manufacturers. There's a middleman, a wholesaler. We have a couple of large companies that are the largest number of our wholesalers. So Cardinal is an example, Bergen Brunswick is an example. There's other large companies, but these wholesalers basically order medications from all the manufacturers, and the pharmacies then order from the wholesalers, and the wholesalers send the medications to the pharmacies. And that's how pharmacies get their inventory. So when the the wholesalers have always been under scrutiny to ensure that what they're sending is appropriate to the pharmacies, that pharmacies are not over ordering. And this scrutiny has really been heightened with the injunctive relief agreement and negotiations with the Department of Justice. Basically, the wholesalers had to address the fact that at one point they were over supplying opioids to pharmacies and that they contributed to the crisis. And so they have worked their suspicious order reporting system, or SOARS, which is set up to identify over orders, large orders, or inappropriate ordering of pharmacies. It's a system that's set up to identify problems. And the way it's set up is the wholesaler has a formula, and the formula looks at ratios of non-controlled substances to controlled substances, and also order history over time, and it makes an automated decision as to whether the pharmacy is appropriately ordering medications. And pharmacies, this is intentionally set up as a system so that pharmacies can't game the system. They wanted to make sure that pharmacies weren't tricking it. So, because of that, pharmacists don't really know when they put the order into the wholesaler whether they're going to get what they order. There's lots of reasons. It could be because the system thinks they're over ordering. It could be because there's a shortage of a specific medication. Um, a host of different reasons why the pharmacy doesn't get the medication, but they put an order in and then the medication may or may not arrive. And so that's one of the factors when pharmacies tell you that they they don't have it, they weren't able to get it. That may be part of the inventory issue. The other thing I will tell you is that pharmacies don't want to be identified through SOARs, because when the wholesaler identifies a pharmacy through SOARs, they are obligated to report to the DEA. So pharmacies don't want to overorder and then have a report go into the DEA. And so that is a reluctance factor too, just because the way the system is set up. Similarly, the stores themselves have dispensing system, I guess, stop gaps that are put in there for the same reason that the wholesalers have done what they've done, which is that the chains, Walgreens, Walmart, Walgreens, CVS, and Walmart have all been included in these injunctive relief agreements, and they also had to identify what they were going to do to address them. And so a lot of the systems have addressed this by putting in basically measures in the dispensing system where when the pharmacist goes to dispense the medication, if the quantity is too high, if the dose is too high, if there's a distance issue, there's certain things that trigger the dispensing stop system. And it doesn't prevent the pharmacist from dispensing, but it may require the pharmacist to contact the prescriber. So I know I've been getting calls through Max for the last few years where prescribers have been really frustrated because they're like, why is a pharmacist calling me to question this, what seems like an appropriate dose or a standard dose for a patient? And it may be because the dispensing system is basically requiring them to do it. Then another area from a regulatory perspective that really causes a problem is e-prescribing. A lot of this is unintended consequences of what are supposed to be good systems. So e-prescribing helps to reduce diversion by having the prescription go directly from the prescriber to the pharmacy, which is great. But e-prescribing, there's DEA regs about the transfer of e-prescriptions. It used to be that an e-prescription that a pharmacy couldn't fill couldn't be transferred at all. So if the patient came into the pharmacy to pick up their buprenorphine and there wasn't any buprenorphine, they'd have to contact the prescriber and the prescriber would have to send that prescription somewhere else. There have been changes to the regs and the pharmacy can now transfer the e-prescription, but they have to transfer it electronically. And so within CVS, that might not be a problem to transfer it from one CVS pharmacy to another, but just like EHRs, pharmacy prescribing software doesn't communicate with other pharmacy prescribing software, so CVS may not be able to send that prescription to Walgreens. From on a pharmacy level, there's a lot of staffing shortages going on, and pharmacists don't always have the time that they really need to do things like fill out a form to let the wholesaler know why they needed the order they needed, so they can do that to address when they don't get the prescriptions they need, but that takes time and certainly delays the dispensing. Making these phone calls take time. And so having staffing shortages prevents pharmacists from being able to provide that extra layer of care. Reimbursement and payment, and I saw that on our list as insurance issues, is really a big problem right now. So a couple of things. One is pharmacies get reimbursed for mostly just dispensing medications, not providing other types of services. And so that can sometimes be a factor in what the pharmacy has time to do. But particularly when we look at insurance coverage in the state of Maryland, Medicaid covers all of the medications, but the generic formulation of buprenorphine naloxone film, for instance, requires prior authorization. And there are some pharmacies that can't afford to stock Suboxone. So when you look at like Home Depot versus a local mom and pop hardware store. Home Depot can afford to buy saws for much cheaper because of the purchase power that they have versus a local store. And so the local store may have to charge more for that saw. And that's the same with medications. There's buying power with an org like CVS that a little independent pharmacy doesn't have. And the reimbursement for medication is the same reimbursement whether the pharmacy paid a lot for the medication or a little for the medication. So I have talked to owners of independent pharmacies that have said that they would love to stock brand Suboxone or they would love to stock buprenorphine naloxone even in the generic formulation, but they can't afford it. Or they can afford to stock a high volume formulation or strength like the 8.2, but maybe they can't afford to stock some of the lower formulation doses because they don't use enough of it. And then communication is a big problem. I know as providers, you will probably have stories about how you've tried to get in touch with the pharmacist and you haven't been able to. And the pharmacists have the same problem when they have questions or when they need more information. Trying to get through to the provider can be really hard and time consuming. And those prescriptions end up getting set aside and not filled in a timely fashion because of this communication issue. Then I would be remiss if I didn't talk about employee level issues. So when we look at pharmacists and pharmacist training, the last 10 years, 5 to 10 years certainly, substance use disorder education is a required part of our curriculum in pharmacy schools. But older pharmacists, like myself, may not have routinely had that type of education. Now, I will say that the University of Maryland has actually always had a really robust education program around substance use disorders, but not all schools have had that. And in fact, when we look at the literature, pharmacists who graduated 10 years or longer from pharmacy school were less likely to have had substance use disorder education as part of their curriculum. And unfortunately, not all pharmacists, just like other healthcare professionals, keep up with standard of care. And so there may be misinformation or lack of education because of that. Stigma certainly plays a role. We know that stigma among healthcare professionals is a big issue, and pharmacists are part of that, and pharmacy techs. And so that is an area that may limit care. And then misperception around specifically diversion. Pharmacists are in a really unique role in some respects because it's always been our job to try to determine whether there's a diversion occurring with specific prescriptions. And so controlled substances are scrutinized. And even though if you look at the literature with buprenorphine diversion is often related to lack of access to treatment and self-medication, and much less so due to, say, diversion for enjoyment or trying to get high. Buprenorphine isn't generally diverted for that reason, but there's still a lot of concern with pharmacists around diversion, maybe in some cases a little bit too much concern. And so that plays a role. But pharmacists do have a very important obligation to prevent diversion. So I want to talk about some solutions. There is a new guideline that was just published. It's called the Pharm OUD guideline. And the purpose of this guideline is it's not really to present new information. It's not a guideline for treatment. It's actually intended to inform buprenorphine dispensing decision making for community pharmacists. So to help community pharmacists make decisions. And it is a guideline that was actually published in, I guess, in concert with or blessed by the National Association of Board of Pharmacy and the National Community Pharmacist Association, both of which are very big organizations that community pharmacists work with on a regular basis. So this has a lot of national pharmacy support. And this is a little quickie guideline or outline of the steps that pharmacists should be taking to ease access to buprenorphine, access issues to buprenorphine based on this particular guideline. And I'll let you read these at your leisure. You will certainly get a copy of the slides, but I do want to hit some highlights. So the first sort of overarching highlight with this particular guideline is the importance of maintenance with buprenorphine or making buprenorphine available in the community pharmacy. And so one of the main highlights of this is the point that declining to dispense buprenorphine should be a last resort effort only after discussion with the patient and the prescriber and with evidence of diversion. So whenever possible, we should make buprenorphine available when we have it available for patients. And in fact, that pharmacists need to be part of the comprehensive care for patients and specifically to prevent pharmacotherapy interruptions. And this can even include the use of a collaborative practice agreement. So some of that newer information that I was presenting with the slides, this really kind of supports that we need to play a bigger role and expand access and not in any way prevent access to buprenorphine. Some area where I get, again, there's concern with pharmacists is misuse or diversion. And pharmacists should be routinely reviewing the PDMP and looking particularly for indicators like multiple buprenorphine prescribers or multiple prescriptions. And this could potentially be an indicator that requires at least obtaining more information, talking to the patient, and also getting a little more information in the PDMP itself. But we do know that there's lots of reasons why there might be multiple prescribers or multiple prescriptions. So patients may be transitioning from care, and so going from one prescriber to another. Or there may be multiple prescribers in the same practice, and they may be seeing different prescribers at different times. This is a chronic disease, and patients are often on buprenorphine for long periods of time. In my collaborative practice, I have several patients that I've been seeing for at least 5 or 6 years, maybe longer. And so when people are on medications for long periods of time, they're going to have reasons why they're there to pick up prescriptions. And actually, I'm getting ahead of myself on early prescriptions. So I'll talk about that in a minute. But again, they may have reasons why they have multiple prescriptions. As far as areas where there are indicators that traditionally have been what we call red flags and shouldn't stand in the way, one of which was early refill. So I was getting ahead of myself a little bit in describing that. But again, when patients have been on a prescription for a long period of time, there's going to be times when they're on vacation, they're moving from states, there's something in their life that requires them to pick up an early refill that isn't necessarily a absolute indicator of diversion or misuse. Other places where you might see this as a traditional, what's been called a red flag, and we really need to dig in on and not use as a reason to prevent access to buprenorphine include things like distance, or the person is obtaining their prescriptions through telehealth, they're paying in cash, that it's a buprenorphine monotherapy prescription. In this day and age, people don't always have access to close prescribers, and so they may have to travel or they may need to be treated through telehealth. And again, this is a chronic disease, and so it makes sense that they would have regular care set up through systems that are going to be convenient to them for care. And so we just need to make sure as pharmacists that this isn't a stopgap to access for patients. We also need to have employer oversight is basically what these guidelines suggest. And so pharmacy policies need to allow pharmacists to exercise professional judgment in dispensing. And so that means that if one of these type of red flags pop up in the system, but the pharmacist recognizes that this is a patient they've been seeing for a while and they understand for distance or they understand why they need an early refill. They should be able to dispense that prescription and not have to still call the prescriber. So pharmacists need to be able to use their judgment. And then there certainly should not be policies. I'm hearing a lot about policies that are based on numerical thresholds or distance or days supply. There shouldn't be magic numbers that slow down or gum up the process for patients being able to get their prescriptions. So this is our next word cloud. I really appreciate all your participation. This time we're going to look at we talked about all these barriers and strategies. I did present the Pharm OUD guidelines strategy, but I want you to scan and let me know what strategies you've been using to try to address some of these barriers. Ooh. I thought it would be on the next slide, but I see participants are typing, so it looks like it's just going to populate on this slide. So please put in again in a word or two any barriers that you've been successfully using. When I see people typing, but I don't see anything popping up. Am I doing anything wrong?
No, it's working.
Oh, can you see them?
I can see the
Oh,
option.
here they come,
There we
here they
go.
come, yay! I wasn't patient enough. That's what the problem was.
Dr. DePaula, I'll just note some suggestions in the chat. And this individual might not be able to use the word cloud, but it says best practice might include telehealth visits outside of work hours, community education and engagement at the level of education of the masses in that community. So those are in the chat as well.
Great, great. And I see others are also talking about communication and technology and education. So it seems like that's a really great ongoing theme. Telehealth, integrated messaging, which again goes back to integrated messaging is a wonderful solution. And again, with that study that I presented, the first study with Wu and colleagues, they had an integrated system and were able to message each other, and that can really make a big difference as far as communication goes. Ooh, discount cards and websites to make it more affordable. Yes. A deductible and trying to address deductible issues, particularly with commercial insurance. Sometimes the deductibles can be really high. And that's often why you see, not often, but one of the reasons you see buprenorphine prescribed is a buprenorphine monotherapy because it's less expensive than the buprenorphine naloxone combination. And so in some situations, particularly where copays might be really high and people are forced to pay cash, buprenorphine monotherapy might be prescribed. All right, great, 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 great. Up social equity training, absolutely. And I think education for healthcare professionals and including pharmacists is really important. So here's a couple of my suggestions. Again, some from personal experience, mostly from the literature. So from a patient education perspective, I think it's beneficial. And again, this is cited in the literature. It's not just my opinion, but it's beneficial to educate patients about the system and what might be potential roadblocks for them. So having them try to fill their buprenorphine at the same pharmacy can be really important. Number one, it allows the pharmacy to maintain their inventory and their stocking so that they're less likely to have issues if they need the medication getting it from the wholesaler. Where pharmacies tend to have more problems is if there's a lot of waxing and waning in their needs or there's a sudden big change. So getting your prescription filled at the same pharmacy helps that pharmacy stock and not only stock buprenorphine in general, but the strengths that you need and the formulation that you need. And then along that same lines, actually getting all of your prescriptions from the same pharmacy is great if that works for the patient. And the reason for that is a couple fold. Number one, it helps you establish a relationship with the pharmacy staff, which can be really important, especially if the patient needs help. And it also allows the pharmacy to check for drug-drug interactions. Sometimes the community pharmacy is the only sort of central deposit, I guess, for all the medications that the patient is taking from various prescribers. And so getting everything filled at the same pharmacy is great from a safety perspective for the patient. And then I think it's really important for patients as much as they possibly can to be their own advocates and understand what is covered with their insurance. What's their copay going to be? Which formulations are covered? I know that's hard. My insurance, I'm constantly getting letters every year about medications they're adding on and taking off. But if at all possible, if the patient can be aware of the insurance issues, they can bring that up with the prescriber right away. Like, this is going to be an insurance issue for me. Could you prescribe this instead, etc. So those are some things that patients can do to advocate for themselves. From a prescriber perspective, having a relationship with a pharmacy that's recovery friendly and has good communications, it can be really important in resolving problems. Now, in the three different collaborative practices that I have practiced in, we've established a relationship in all of those practices. I've been managing patients who are being treated with buprenorphine, and we've established relationships with a local independent pharmacy. We never required our patients to go to that independent pharmacy. We just referred them if they wanted the referral. But we had really great communication. It was small. The pharmacist had our phone numbers. We had their phone numbers, and we were able to quickly resolve problems. And we knew the pharmacy was going to stock what we needed. So if you can establish that type of relationship, there's nothing to say that the local CVS pharmacy might be equally good. Nothing to say that a chain wouldn't work just as well, but a pharmacy that you can establish that type of relationship. Certainly when problems arise, if you can try to address them as quickly as possible, call the pharmacy right away. That can be really important in making sure that that prescription doesn't get set aside. And then the literature had suggested automatic refills sent electronically to the pharmacy. So if you know that a patient is going to need a refill and you're doing refills, if you can do that on a more of an automatic basis, that can make a difference in making sure that the pharmacy receives it in a timely manner. Certainly, if practice issues come up, I'm here representing Max. I've given you some examples of calls that I've gotten both from the pharmacy side and questions from the pharmacy and also from the provider side. So if you reach out to Max, we can help work through. They'll connect you with the appropriate consultant, which may or may not be me, but we can help resolve your problems. Then advocating on a regulatory and policy perspective can go a long way in trying to solve some of this. So some of the suggestions have been to try to advocate to have buprenorphine removed from order algorithms and source reports so that it isn't part of the whole wholesaler and ordering issues. Also having state and federal regulations potentially that mandate that pharmacies stock buprenorphine. I do think because of cost issues, I don't know how possible that's going to be, but that's been suggested in the literature. Having CMS, state or private insurers prohibited from requiring prior authorization for certain formulations. That can make a big difference. And then exemption from in-network fill restrictions. Sometimes when patients are required to fill within a specific network, if those networks don't have buprenorphine or the network isn't close to where the patient is, it can disrupt care. So that's also been something that's been suggested in the literature. So in conclusion, pharmacists can be better utilized to address OUD treatment shortages and expand access. However, we need to identify some of these regulatory and pharmacy level and individual barriers that affect patient access and continue to really work on creating solutions. So that leads me to questions and certainly any discussion that you want to continue based on the word clouds. I'm open to that as well. I'm going to go ahead and stop sharing.
Thank
And
you
you
so
can come
much.
off the mic or jump into chat. I can open chat now and actually look at chat.
Thanks, Dr. DePaula. I mentioned here in the chat, if folks want to add something in the Q&A or the chat, it looks like we have a question in the Q&A. I don't know if you see this, but I'm happy to read it for you.
Okay.
How would you suggest explaining comprehensive treatment policies to pharmacies or pharmacists? Examples, alcohol withdrawal management or benzodiazepine weaning or tapering. general but evidence-based letters or phone calls?
So, and I guess I don't know if you want to provide a little bit more information because I don't know if we're talking about community pharmacy education or pharmacists in inpatient or ambulatory care setting. I'm going to start by answering how to get educational initiatives out to community pharmacies because I'm thinking maybe, but feel free to add if that's not what you're asking as far as question goes. So there have been a lot of initiatives around, and this is just one step that I've seen used across the board and particularly with community pharmacies. But there's been a lot of efforts around what is known as academic detailing. And academic detailing originally comes from the effort to kind of counter educate around drug companies often come in, pharmaceutical companies often come into different settings, either ambulatory settings or inpatient settings and provide education. And a lot of prescribers were getting education from these type of one-on-one meetings. And so academic detailing was sort of developed to provide messaging that we want to share from a hospital level or from a public health level. And there have been a lot of initiatives around that. The VA utilizes that with their healthcare providers. And there's been some literature. I actually had a project many years ago looking at academic detailing. So that is one-on-one. That is actually going into the pharmacies where there are pharmacies that need more education and educating on specific points. My project actually was peer-to-peer. So we had pharmacists and pharmacy students that were going into the pharmacies, but I know the health departments have also been doing some academic detailing. And I think direct messaging is a great way to, number one, actually find out what the questions are and answer, as opposed to you can certainly send letters, you can send educational bulletins out to pharmacies, but sometimes that stuff gets overlooked. And so this is more of a direct way to teach and also to really understand what the questions are. I think another really great way to get messaging out is through large state orgs. So the Board of Pharmacy puts a newsletter out. The Maryland Pharmacists Association puts a newsletter out, and that's a great way as well to get some information if we have some central education points, like about naloxone, for instance, or about buprenorphine access and change of the data waiver. That is one way to reach pharmacists in general, and particularly community pharmacists. So hopefully that answers your question.
I see another,
I'm going to
this,
throw in one more plug too.
okay,
Max, I already said Max, but if you reach out to Max, I do a lot of one-on-one educations. I called a pharmacy this week to find out what issues were around buprenorphine access and did some education. So we can help you too. I should have plugged that first.
thanks, Beth. The follow-up here says mainly an issue with larger chain pharmacies, which some patients are required to use, in parentheses, CVS. So
Yeah. Um, so again, some of what I just mentioned, but also sometimes we have to do some reach out to their leadership. If there's some central issues, we need to find out about company policies and talk through with the leadership as far as opportunities to educate. So I happen to know for a fact that a couple of years ago, there were some community pharmacies like Safeway and some of the chain pharmacies. I can't remember if CVS was one of them. I think there were CVS was, where they took on big educational initiatives around naloxone and they were making naloxone available. And some of that happened through discussion with when I say leadership, at least state level, like division, administrators, branch administrators were able to help share education. They often have to have things approved at a corporate level before they can share it with their staff. But again, when we were doing our academic detailing project, we had literature around naloxone, and we actually went to each of the chains and got permission to share that information with the chains. So sometimes if you can pick a region and then kind of work at a regional level, that can make a big difference for education. But it is a hard problem. I don't have a one-stop answer for how to get information out.
Well, thank you for answering that. We have hit the 1 o'clock mark, so I think we'll call it here. If anyone has follow-up questions or thoughts or cases you want to talk about, you can feel free to reach out to us. We can facilitate or tee that up to Dr. DePaula. We're happy to continue the discussion. So you can feel free to give us a call or an email. We're happy to make that connection. Thank you, Dr. DePaula, for an engaging and I think really timely discussion. So again, feel free to reach out. Thank you for the time today. We will make the recording available within about a week. It will be on our website. Thanks again. Have a good afternoon.
Thank you, everybody.